So just starting off the examination, going through it, the first thing we appreciate is that there are chord plexus cysts. So examining the fetal head, again, like to have a high degree of magnification. On my, where's my VRSI setting gone long? Can't see my VRSI setting.
What?
The VRSI.
VRSI? It will be good. You turn on.
Oh, there it is. Okay. So the first thing is just looking at the fetal head here. Come down my magnification. I like to have my VRSI. It just produces it's speckle reduction and just produces a sharper image. So the first thing to do is in sweeping through the fetal head, I see that there are bilateral chord plexus cysts. Sometimes chord plexus cysts can be so large they can make the ventricles enlarged. But when I see that, it's a feature of trisomy 18. The likelihood ratio for chord plexus cysts and trisomy 18 is 9. So it increases your chances of trisomy 18 by a 9-fold. When you look at the shape of the baby's head, you can appreciate that the shape of the head does look a little bit strawberry shaped. Again, another sort of feature, and that's where you get that widening, narrowing here, and then the wider appearance. So that's the second thing that you see. As you come down to the baby's hands, you see that you want to look to see that the hands, so that the thing that you get trisomy, the index finger goes over. But on the first trimester, you don't see this. It only happens later. It's usually by the mid-trimester that this manifests. So at this stage with trisomy 18, it's beginning to get to the point where the hands cross. So you may not see it, so don't rely on that. As you come down to looking at the baby's heart, you come down to a 4-chamber view of the heart. So the next thing I do is now I'm on a routine setting. I'm going to go to a first trimester cardiac setting. And as I do so, my hertz is at 70 hertz. I'm going to slightly reduce my sector width. No, it's too much. And then I'm going to go to HD zoom. So I start off by taking an image, and I split the image, and I look to see where's the stomach. So with trisomy 18, you can get esophageal atresia, a tracheoesophageal fistula, and I'm finding it difficult to see the stomach. So the heart's on this side. I'm going to ask whether that's the stomach there, but I would expect to see more fluid in the stomach. So the first observation is that's quite a small stomach. But I need to wait, so I'll come back and examine that a little bit later. But that makes me suspicious of a tracheoesophageal fistula, esophageal atresia with a tracheoesophageal fistula distal, if I've got a small stomach. I then come up to looking at the heart, and as I start the examination, I see my size, axis, rate, rhythm cycle, SARRS. So as I look at that, I see that the size, the axis, rate, rhythm are normal, and the cycles is normal. I've established that the stomach is on the left-hand side. When I go to examining the heart, now I go in, I see I have a rib on both sides, and when I'm looking there, I can see there's a ventricular septal defect. So if I look in the center there, I see a ventricular septal defect. I see that the left cardiac ventricle is smaller when compared to the right. So I magnify the image of that. It's very important when you see that the ventricle, one ventricle is smaller than the right, then you need to look at the sizes of the mitral valve and the tricuspid valve. So this here is looking here is the mitral valve on this side here, and this is the tricuspid valve on this side here. So I can see that there's a very different, significant differences in the sizes of the valves. Once I've got that on view, I'm going to go to color Doppler because we're at 16 weeks of gestation. And on color Doppler, my PRF is at 23. I'm going to increase my PRF up to 31, up to 48. I'm going to pull down on my acoustic and my power output, and then I'm going to change my gain. So now I'm looking at the 4-chamber view of heart, and what I'm looking at in the 4-chamber view of heart is just to see if there's any evidence of tricuspid valve regurgitation or mitral valve regurgitation. As I'm looking, I'm seeing normal inflow in both the left and the right ventricles. So that to me looks like normal appearances, but I appreciate when I look at the size of the right ventricle and the left, that the left ventricle is smaller when compared to the right. So there's ventricular discordance and a perimembranous ventricular septal defect extending into the muscular portion of the ventricular septum. So that's and I say the cine loop of that. Once I've got the 4-chamber view of the heart, I then sweep from that out to looking at the outflow tracts. I have an arm over the chest here, which is casting a shadow straight through the heart. So when I look at the pulmonary artery, I can see the pulmonary artery and the transverse aorta is very narrow. So the left ventricle is small and the transverse aortic arch is very narrow. When I look at the level of the isthmus is very small and the pulmonary artery is large. So that combination of seeing a small left ventricle with a 3-vessel tracheal view, which is a narrow transverse arch, is a feature of coarctation of the aorta, number 1, and mitral atresia with ventricular septal defect, number 2, interruption of the aortic arch, number 3. So they're the 3 differential diagnoses. I've excluded mitral atresia with VSD because I can see normal inflow into the left cardiac ventricle. So I'm left with either the possibility that this could be either a coarc or interruption. So as I look at that view there, I'm going to magnify that image, and then I'm just going to say the cine loop of that image, showing the caliber of the pulmonary artery in relation to the transverse aortic arch. You will see I'm not getting any fill of these vessels. So what I'm going to do is I'm going to save that cine loop, and the next thing I'm going to do is I'm going to go to a setting with not graphic but power Doppler, and now I'm going to, in power Doppler, I'm going to reduce my PRF to see if I can get fill in the transverse aorta. If I'm not getting any fill, my next step is to go to slow flow. And when I go into slow flow, I go back into the map of 4. I'm going to see if I can get now flow. If I can't see what's going on, then I'll split my image into a 2D and 2DC, and then that will give me both my transverse aortic arch and the aorta. So at this stage I'm finding it difficult to get filled. The reason I'm finding it difficult to get filled is because the position the baby's in. So I need to go into a better position. But it's in a good position for looking at something else. If it's not in good position for one thing, it'll be in good position for something else. And if you look up here, I'm going to put my slow flow at radiant. I'm going to put it up to max. And now I can see this is the left brachiocephalic vein, which is not dilated. With anomalous pulmonary venous return, you will see it's dilated, or either in a central nervous system, vein of Galen aneurysm, or severe growth restriction are the 3 reasons why the left brachiocephalic vein would be dilated. As you look coming across in this, you can see that the subclavian artery and vein, I'm not getting a full display of them, so now I'm going to increase my power output. I'm up to 90%, and my color gain, I'm just going to pull back on my color gain if I can't get my subclavians into view. I'm going to go a little bit further acoustic output and pull back. So now I can see the subclavian artery and vein, this side here particularly, because if you look down here, this is left, and if you're going to have an aberrant subclavian, then it's going to be on the far side. So I look to see if there's any evidence of an aberrant subclavian, and that subclavian artery looks normal. So you can save that image and save that to hard drive. What I do notice in this baby is I'm looking at the left brachiocephalic vein, that there is no thymus gland that I can see. So if I split the image, I'm seeing a very, very small thymus gland. So when you see a small thymus gland, you always suspect a possibility of 22q deletion. So this structure here, generic area, this structure here, trace, this structure here is the thymus gland that I can see. This to me looks quite a small thymus gland. And if I ever want to see the boundaries of the thymus gland, if you just go in anterior to this, I need to pull back. I need to look for the internal thoracic artery and vein. This here is the internal thoracic artery, just coming off here, that's on the near side, and I look for the internal thoracic artery, which is just coming in the far side. If you're seeing too many vessels, then pull back on your acoustic output and pull back on your power gain, just to catch the artery and the vein. Sometimes you can see them on 2D, but the thymus gland to me just looks a little bit small. And so in summary, we have a 1, ventricular discordance, 2, a perimembranous ventricular septal defect, which is extending into the muscular portion, 3, we have a slightly dilated main pulmonary artery with laminar flow, and we have a narrow transverse aortic arch. With regard to the rest of the baby, because we know there are other associations, so if you're seeing cord plexus cyst, strawberry-shaped head, coarctation, VSD, you need to look to see if there are other key markers of aneuploidy. So the first you need to look for is facial clefting. So you divide the image into 2, you come across the alveolar ridge, you check to see that the lip is intact, and there's no sign of any cleft. Then I go down to the mandible. I see here there's a gap in the mandible just here, which is the mandibular gap, which tells me it's very unlikely that it's going to have micronaphlia. So that's normal. So I save that clip. As I come down to the hands, I said it's maybe too early to see the crossing over the finger. So if you look at this image here, you follow the index finger, you see the index finger has not crossed. It's only 16 weeks. If you scan at 20 weeks, that index finger will be crossed. So only a small proportion of these in the second, first or second trimester will have that. I go to look at the feet because I know that there's also association of rocker bottom feet with trisomy 18. So you want to see the angle in which the feet comes off the lower leg to see if there's any evidence of extension of the heel. So when you're looking at rocker bottom feet, you're looking at this point here where the heel goes further back, but that's normal. So there's no signs of a rocker bottom feet. And again, when you look at these rocker bottom feet, again, that seems to be something that is seen sort of later in the pregnancy rather than now. Since I've got both legs on view in this view, then I say that is a semi-loop clip. We know that spina bifida is also a feature of it. When we look at the landmarks for the midbrain brainstem, to me it looks normal. So this is your brainstem. From here to here is your brainstem. This is the anterior border brainstem, posterior border brainstem. They look normal. And I've also done a 4-segment analysis. So this is your intercranial translucency here. This is your 4th ventricle just here. And this is your brainstem here. And they look normal to me. There's no signs of shift. So that looks fine. With regard to the facial profile, I look to see with regard to the nasal bone. I look to see if there's any evidence of micronaphia, but I'm not seeing anything. And to me, this looks like a normal profile. With regard to the nasal bone, I needed to move into a better position. So then I come down to looking at the both kidneys. The kidneys, you can get hyperechogenic kidneys with trisomy 18, more commonly, however, in trisomy 13. But when I look at the texture of those kidneys, the texture of those kidneys to me looks okay. You look at the kidney on their side. I'll just quickly go and change to a linear 9. Thanks. What I want to look at is in terms of the linear 9, I want to look at the go to first trimester cardiac. I'd like to get a little bit more detail with regard to the
Đúng đó, chính là đó.
how about this one?
This one.
Let me just try this one.
No. We not disconnect this one.
Maybe if we connect it up, I'll just have a look at it if I can. I'd like to see it. I've never scanned with the. I've never scanned with the.
But
This,
which prop you want to check? Prop, transvaginal prop. I will check out the return, and then on
yeah,
the-
we can do that. Yeah, we can do that.
Cái điều làm anh như là tiên đều vẫn phải nghĩ là dân không có cho những cái em hoặc là những cung thì nhiều đâu thì nói những người đó nó rất tiên phải không ơi
Tôi nghĩ một hai là chỉ sáng em hoặc sáng cung, hai là mitral tracia, tại vì ngón trái nó nhỏ.
nó hơi nhỏ nó cần sửa lại cái gì
Thanks.
ông Hùng là ông có đang xu hướng là mình sửa không hay lại luôn đi đồng ý dùng cho
Chỗ
mình
nhỏ cỡ
cái đầu mở này đang sửa lại trong này mở lại
So when you look at this high frequency probe, you can appreciate the size of the ventricular septal defect just here. When you look at a ventricular septal defect, you are looking for 3 things. The first is you are looking at is dropout in the region of the ventricular septum, and the next you see edge enhancement. You can see edge enhancement on the far side and edge enhancement on the near side. In fact, edge enhancement can be an extremely valuable marker for very small ventricular septal defect. Can I take this off long? Is that okay? Or you prefer leave it on? Leave it on?
Hải muốn
Can I take this off?
tháo
Is that okay?
Của bên em không?
Or you
Okay,
prefer-
okay, that's okay.
Are you sure?
That's okay. I will put it back again.
Thanks.
Này của Mỹ hay đâu phải của mình đâu.
So when you see this echo here, this is a very, very important echo to see because it allows you to pick up VSDs very early in pregnancy, but at any stage in pregnancy. For me, it's a very powerful marker of seeing ventricular septal defect, seeing that little echo, that which is edge enhancement as a result of the defect, just there. It's tiny, but that just tells me that that's where the VSD is. And if you look at it here, we're looking at this point here to this point here. Because the VSD is so large, I am surprised that there is a discordance between the ventricular sizes. This is unusual because you would expect with a VSD of that size not to have such significant discordance in the ventricles. It surprises me. So anyway, sometimes you get surprised by things, but it always makes me think, is there another reason why the left ventricle could be smaller? And so I can't find, as I said, when I looked with color Doppler, I could not see any evidence of a mitral atresia with VSD. To me, the inflow looked normal, just change the size. With regard to this not seeing the stomach, I'm going to come back to the stomach, and I still can't see a stomach, so I think I'm concerned about the possibility of tracheoesophageal fistula. So if I come back, it's just I'm not even certain that is the stomach. So seeing that combination, so seeing that's the situation where you're not seeing, I should see a decent sized stomach if it's small. And getting tracheoesophageal fistula is something that we know happens in babies with trisomy 18. So it's just another marker to bring it into view. With regard to looking at the pulmonary artery is much larger than you'd expect. When you look at this with a linear probe, you can see how much more easy it is to appreciate that the transverse aortic arch is significantly narrowed when compared to the pulmonary artery. So if we look just to that point, this is a very narrow transverse aortic arch. So it's like a tubular coarctation. There are two types of coarctation. You can either have a focal coarctation, which just occurs at the level of the aortic isthmus, or you can have a tubular. Tubular is far more common than we pick up. This here is the coronary sinus. When you look at the distance here from here, this is the coronary sinus extending up. No, this is the coronary sinus extending from here to here. And that to me looks as a normal, I'm not worried about that coronary sinus. But if I see a coronary sinus that looks a little bit prominent, just check beside the pulmonary artery, always beside the pulmonary artery. There should never, ever be a vessel beside the pulmonary artery. If you ever see a vessel beside the pulmonary artery, the most common explanation is bilateral SVC or persistent left superior vena cava, or the ascending vein of a total anomalous pulmonary venous return. So when I see the coronary sinus is easy to see, I just do a quick check and I look at the pulmonary artery and I say, is there any vessel there? And there's no vessel there. And also, if there is a bilateral SVC, the right SVC will be smaller. So this is an SVC that's a good size SVC, and therefore that does not support bilateral. If it's bilateral, this will be smaller. So looking at the sizes of the SVC, relation to the pulmonary artery and the aorta tells me that that SVC is okay. But again, just come back, you see the way I'm getting filled, there's too much echoes in that. I'm going to increase my dynamic range and I'm just going to pull back on my color, and now I get just a clearer definition of the vessel. I'm going to now magnify the image of the vessel and then come across to the transverse. Now you see, if you want to, you can put them side by side. So this is the transverse aortic arch just there, and this is the pulmonary artery just there. So if you look at the sizes of these vessels, and we would in the third trimester, the next thing we would do in press calc, we go to fetal echo Z-scores, and then I do the aortic arch, and then I choose the aortic isthmus, and I will Z-score the aortic isthmus at this point here, across to here. And then the next thing I'll do is Z-score is the pulmonary artery. So if we look at the four chamber, right ventricle, where is it? Where's the MPA? Short axis MPA. Thanks. And we do a Z-score on that. So that'll give us a Z-score of aortic isthmus of -1 and then an NPA of 2.39. So you can see the ratio between those Z-scores that would fit with somebody with a coarc. It's important when you see something like this is to look at the left ventricular outflow tract, because with aortic interruption you will get a VSD in which there's posterior malalignment. So I need to try and get a left ventricular outflow tract. So if I come down on this image, and I'm going to change the transducer to C2 to 9 to try and get this. So as I come up to an LVOT, so I'm just going to slightly increase my dynamic contrast. So to get the LVOT, I get the 4-chamber. I'll be able to incorporate. So this is just catching here the aorta rising from the left ventricle. And what I'm looking to see is when you look at the interventricular septum, it then falls back into the left ventricle in a baby with interruption.
Fall back? What do you mean by fall back?
It's malaligned posteriorly. You know, in tetralogy of Fallow, you have malaligned anteriorly. You get malaligned posteriorly with interruption. Yeah. Yeah. So the two things that help you in terms of working out with regard to interruption is, first of all, when you look at the left ventricular outflow tract, it does not have a curve; it goes straight. And the second thing is when the VSD is associated with its posterior malaligned VSD. So I'm going to try and just get a better view of the LVOT. It said, can I do an internal? Yeah, maybe.
Want to TB?
I just, yeah, if she's, I'll have it. It's worth maybe trying. I don't know. It's a 50-50 chance long it'll work. Long, is there another patient waiting, or are we okay?
But no. One more.
One more, yeah. Okay. I can try transvaginal to see whether there's posterior malalignment. But before I do that, just let me finish up TVT.
11.
Sure. What have I got? Yeah, I'll try the 11 in a sec. So I just want to finish up just checking the rest of the anatomy on the baby. Always important just to check the placenta. So I always look to the placenta just to make sure it's not thin. Because if the placenta is very thin, then I'm looking at digonic triploidy. And that placenta is a normal thickness. So there's no signs of digonic triploidy doesn't fit. Also, in terms of digonic triploidy, the other way I'll pick it up is when I look at the abdominal circumference, I'll see the abdominal circumference will be below the first centile. And to get an idea here, I will see that this is the abdominal circumference here, and I just do a quick comparison to the head circumference on the same image. So in the setting of digonic triploidy, my AC will be something like that, whereas that's normal. Okay. So we've looked at the head, brain, fourth ventricle, nuchal translucency, orbits of the eyes, lips, mandible, maxilla, 4-chamber view of heart, outflow tracts, cord insertion to the abdominal wall, urinary bladder, femurs, feet, hands. Yeah, we've done everything. I just need to do the spine. So important to check the spine just to see that there's no signs of a spina bifida, hemivertebrae, just to make sure it's not part of vactral. Bring the image up. And again, when you're looking at any bony points, just increase your dynamic range. It just gives a sharper definition of the bony structures. So looking at that, I want to see if there's any evidence of any hemivertebrae. I can see the skin line sort of coming down very nicely over the back of the baby's spine, so I save that. And if I increase my SRI, it just gives a nice, sharper definition of those structures. So that, to me, looks like a very nice, normal-looking spine. When you look at the end of sort of L1 to L2, where the sort of spinal cord ends and then continues as the chorda equina. You can also see the kidneys on this side as a split image. Hang on, just let me do that. I'll just save this image first. Look at that, and then I can see the kidney on this side, and then I go across and I'll see the kidney on the other side. Just check it does not have a duplex. So we'll come back to have a look that there might be a duplex on that side, but it's a normal on this side. So in terms of me checking for a duplex on that side, I'm going to come around to looking at a coronal image. No, it's not duplex. It can be very easy to make a wrong diagnosis of duplex, but that's actually a single renal pelvis just coming out here on this side. And a single renal pelvis, then it divides into two. So that's not duplex, so just be careful. So I'll just show this to you here by making this look duplex and making it look normal. So this makes it look like a duplex, so I'll just press P1. This looks like a duplex, right? You agree? And then this image here shows you that they join as one. Yeah, just as one. So that's not duplex. Okay. And the other thing, when you come across here, you can look at power Doppler, and you look and see the renal vessels just filling. You see, I said yesterday that 30% of women will have a double renal artery coming out to feed it. The kidneys, this is a common normal variation. I think it is slightly higher in aneuploid fetuses. When you go to slow flow, you can even see it's more marked. So you can go into sub-menu, map this, go down to map of 4. And now you can see, in fact, there are actually 2 renal arteries coming out on the near side. So I just wonder whether it is duplex. When I see a double renal artery coming out, it's more likely that it is duplex. Then come back to main, and then go back to main and increase to max. So then you can see the there's one. If there's too much color, just pull back on the color. Just get a little bit more definition of the tiny vessels. You can see I get the I come down to looking at the descending aorta. Just look at the point at which the descending aorta comes off. If you look up more superiorly, you may get the suprarenal arteries. So to get the suprarenal arteries, you need to increase your power output, and you need to increase your color gain. There's your suprarenal. So if you come off here, this is your suprarenal artery coming up to apply the adrenal gland, just here. Turn up the gain, that's your suprarenal. Stop breathing. Breathe away normally. So this here is your suprarenal. And then these are your renals. Okay, and then I just need to check the legs and feet. And I just want to check the digits of the feet. So I want to just make sure there's no polydactyly. Polydactyly is more typically seen in the setting of trisomy 13. It's not that common in the setting of trisomy 18. And how you see polydactyly is because you note that at this point of the foot it's much wider, and you reference the width of the foot in relation to the heel. Whereas in the setting of polydactyly, you'll find it will be out here. Yeah. Best way of looking at the toes is to look at the toes when they're up in a sort of a vertex position. So. Sometimes when you see a gap between the big toe and the second toe, referred to as the sandal gap, This is most commonly a transient finding that you see, but if it's persistent, it's a marker for trisomy 21. But that to me looks normal. If I look at the tibia and the fibia and fibia look good. If I look at the femurs, I think subjectively the femurs look fine. Always important to check that you look at the femur on the other side, because you can have unilateral malformation of one femoral bone and the other one is normal, and that's certainly, I've seen plenty of those. So it's nice to just have a record of both of those. So that's, in summary, I think that's really everything else we've covered. Nice view of the scapula. So if you come off the shoulder, you can see the nice scapular bone. I look at the scapula only in the setting when I'm looking at for skeletal dysplasias. Then I start looking for the scapula. I look for the scapula and I look for the ilia crest. So you come down, this is the scapula on the other side. So that's the scapula on the other side. So both scapula are normally formed. And when the other things I look for is the clavicles, to make sure that the clavicles are normally formed, and then I look at the ilia crest to make sure that the ilia crests are normally formed. So if you look at there, that's the crests. And I would only look at the ilia crests in the setting, you know, if I was worried about a skeletal dysplasia. I wouldn't look at the ilia crests routinely in terms of looking at a, you know, in routine imaging.
Can we observe the bone of the ear?
Ah, that's challenging. Oh no, you're pushing me.
Because sometimes we don't see the ear and whether we have to check.
No, I know. Yeah, the bones, you can do that in a 3D evaluation. There's a paper written by a French guy. That's not something I'm very good at. But I think, yeah, you can come around and look at the ears to see if there's any sort of striking features of them. And I think it's nice if you look at the ears by looking at well, we can do transvaginally, you'll get a much better picture because it's only 16 weeks. But if you look at we do a first trimester setting on this, but looking at the actual inner ear, I think is what you're asking.
Yeah, okay.
No, I'm not very good at that.
No, just give it.
I don't. Well, I've tried doing what they've reported on in that paper, and I have not been able to reproduce it. They've also reported as well on the septo, the optic tracks on 3D evaluation. I also find that very hard. Stop breathing.
Nín thở chị. Rồi thở bình thường.
Be the way normally, yeah. So when you're faced with a 2D image and you want to know what it is that you're looking at, first of all, I ignore that, right? So I can bring down into a multiplanar, and you can take off your rendered image, and then you can come down and place your reference dot over the ear, and then turn sideways on it, and you can see whether you've got a decent view of the ear or not. And the other thing is you can forget everything, just go to your A plane. Let's say you're completely lost, and then actually I must show you about 3D, how to evaluate in 3D. So I need to bring the image into the center of the picture, place the image in the reference of the baby's face, get both orbits into view, translate until I see the face. And now I have one orbit, now I need to bring around the other orbit. So I need to find out where I am. And once I see both orbits, that I'm in the middle of both orbits, then I know where I am. You see when I'm driving as well, 3D, is I don't necessarily need to look at the buttons. So I think once you become familiar with 3D and you get the point, you can drive the system. You can very quickly in an A plane know whether it's a good volume or bad volume by translating through it. Okay.
Đi lớn, đặt cái lay từ phần này đến phần cơ. Trái nhỉ? Đi
Some I think the paper do on most bigger fetus like
Say again.
the ear, the inner structure of the ear. I think they do on a bigger fetus where they have fully grown.
Fully grown,
Yeah,
okay.
I
Okay.
think so. Because it
Yeah.
a 16, I don't think we can see much.
I don't think so either. But it's not something. Yeah, we just don't do it. I'll just have a quick look with the. Let's try the linear 9. The linear 11. Let's have a look at it. Ooh.
It's for breast and thyroid.
Ah, for breast and thyroid.
Because
Right. They do breast and thyroid here, yeah.
yes,
Ah, right. Okay. Nice view of the kidneys.
just good for the very near field.
Chị đang nghiêm là chị chưa nghi ngờ
Stop breathing.
nín thở xíu là chị.
Breathe away normally.
Rồi thở bình thường nè.
You see the little vessels going out to the pyramids. Okay, last image through a.
If this is a ductless renal kidney, it must be an incomplete ductless kidney, right?
Sorry, say again.
So if you suggest this is a ductless kidney,
Yep.
it must be incomplete ductless kidney. Because if there is a complex ductless kidney, there must be two dilated, one dilated ureter from the upper
True.
pelvis.
Yes, you can have. Well, it depends. Sometimes, mostly they're not obstructed. They're not dilated. So
Okay.
most duplex systems, which you pick up in screening and gynecology, most are in women, and most are not obstructed or dilated. They don't reflux. They don't obstruct. It's the same with babies. Most duplex systems, which we find on prenatal imaging, there's no obstruction, no reflux.
Yes.
And the difficulty is when you see two intrarenal pelvises, you think it's duplex, but it has to be when they leave. In a sense, you have to see two separate points of exit close to the where the renal pelvis is, not inside the kidney, and that's where you make a false positive diagnosis. So if you see two, what looks like in the center of the kidney, I don't call that a duplex until I actually see it leaving. Yeah, because if there's two inside the kidney and they join inside the kidney as one ureter, that's not duplex.
Yeah.
Do you get me?
Yes.
Mà nãy chỉ có một cái cổng ra thôi, nhưng mà lại có hai cái mạch nối luôn.
Cái điều quản không giãn người ta phải hỏi ra một cậu.
Thầy đó nên thầy chỉ nghi thôi, thầy nên là đi đầu dò để thấy rõ được hơn là có mấy cái cổng đi ra.
So there's an absent nasal bone. It's very, very poorly ossified. See the nice foamer?
Dạ.
All right. Do we have another patient?
Yes.
We do. Okay. I'll just take one last picture of the heart.
Có cái tìm cho các bạn hết nhiều.
pulmonary regurgitation.
Okay, pulmonary regurg. Okay, thanks. How many weeks?
This one, this case.
This case.
Oh, it's got pulmonary regurg.
So I think there must be something with the pulmonary valve.
Ah, okay. Okay, let's have a look. Because we haven't really looked at the pulmonary. So the question when you're looking at pulmonary valve stenosis is whether the valve disappears during ventricular systole. So when you look there, you can see that that's diastole and then that's systole. Now during the systole, I think it disappears, but that's only one sign. But when I look at it during diastole, it actually looks quite thick. The valve looks quite thick, but it disappears completely. So, but only way of I be knowing whether this is going to be pulmonary valve stenosis or not. Let's just record. Here. Color. So let's look with color first. So with color I'm at 31 of 16 weeks. I need to go higher. I'm going to go up to 49. My acoustic guidebook I'm just going to pull back a little bit, and my color gain I'm going to pull back a little bit. So if I look at my PRF, I'm going to go up a little bit higher. I'm going to magnify my image, and then I'm going to do a split screen onto 2D, 2DC. So when I look across that, to me that looks more like laminar flow. When I look at that, but I still do the velocities. Did you think it was pulmonary regurg or
Yeah, yeah.
She think of regurg.
regurg? Okay, yeah. I'll have a look now in a second. But that looks pretty good, you know. I mean, I agree that the valve looks a little bit thickened, but it still looks like mostly laminar flow
Yeah.
across that valve. I know my PRF is quite high, so I'm setting at 70 centimeters a second. But if I want to see whether this baby's got pulmonary valve stenosis, I'm looking for the velocities, you know, somewhere, I mean, over 100 at least for significant stenosis. So that's why I'm okay with setting my PRF up to 79 centimeters, which is really a third trimester PRF. And you can overcall pulmonary stenosis if you set your PRF too low. So we'll do the Dopplers now. So we'll just go back and catch the vessel. So I just need to tidy up the image. And then I'm going to place my pulse Doppler gate. If you think there's regurgitation, first of all, I want to look at velocities that are distal to the valve. So I want to look on the far side of the valve first. So I'll do that first. Stop breathing.
Nín thở thì bác sĩ. Nín thở sẽ như vậy.
Breathe away normally.
Rồi thở bình thường.
Get a better picture. Very active baby. Yeah, it's 100 centimeters a second at 16 weeks is slightly increased. Stop breathing.
Nín thở sẽ bác sĩ nha.
Yeah, so peak systolic. Sorry, breathe away normally. A peak systolic velocity. I think probably the best ones are maybe around Vmax. Where's Vmax? Fetal echo
Mention.
Vmax. So if we look at say around there, what are we getting? 106. I need to pull out my chart and look. That's elevated for 16 weeks. Yeah. Let's look to see for pulmonary regurg. And that may be contributing why there's such a difference between the aorta and the pulmonary artery. And also the fact that we're seeing, you know, that there's a big VSD there. We're saying why is the aorta so narrowed. It may be that the pulmonary artery is actually quite dilated. So if we look at this with colour, and we see where there's regurgitation, yeah, there's regurgitation. Who's the doctor who picked up the regurgitation? Were you? It was a very good pick. Yeah, very good pick. So we split the image into 2D, 2DC. So once you get that, you always worry when you see regurgitation like that, and you worry about a pulmonary valve that's dysplastic. You always ask, is there also, is it seesaw motion? You know, is it possible on the spectrum of absent pulmonary valve? But no, I think this baby's just got, it has more regurgitation than it does. I'll just try and get a pulse stopper now, just what you showed me. I'll try and get that.
Oh. Cái này của Hùng á Hùng.
Yeah.
Chưa xanh hả?
Yeah.
Yes, if I thought.
Stop breathing.
Nín thở xíu.
Breathe away normally.
Thở bình thường.
Stop breathing.
Nín thở xíu.
Yes. You can hear it.
Yeah.
Dạ.
So if you look at the regurgitant velocity, it's less than the forward velocity, I think. We listen again. Yeah. So let's repeat it, say that. Very good pick, guys. Very good pick.
Do we have a last stage of the Doppler color like that?
Pardon me?
How much the diameter of the gate then put the color Doppler on the pulmonary artery?
Gate sample.
The gate
First way
Doppler.
Gate
On the gate
Sample
sample.
size.
So the gate sample, it depends where I want to know what the velocity is, where I put the gate. So if I have pulmonary valve stenosis on colour and I see no regurgitation, I put the pulse Doppler gate just beyond the valve. So if we take a picture here and I show you. So it depends what colour tells you where you put the gate. So if I see here that this is the valve and I put on colour and I see that there's no regurgitant jet, then there's no rejet, then I place my gate here. If I see there's a regurgitant jet, and I want to know what the velocity is going forward and what the velocity is going reverse, I use a wide gate to catch both on the near side and the far side.
Yeah.
If I see, in that looking at the tricuspid valve, if I see a regurgitant jet, I want to know where the jet begins. I want to know where is the point of maximum velocity. And you can, when you are scanning, if you look at it, you can update and you can actually hear it and you know where to put it. So if we look in this case here, I decided not to use colour to do it because I could see, in a sense, if I wanted to update, then I would be able to know where to do it. So what I did was I went straight for pulsed, and I placed it over the valve and I've angle corrected it to catch it over the valves. So this is the level that I wanted here. I probably need to narrow it a little bit. And then I asked the patient to stop breathing,
Nín thở xíu.
and then I catch it on the near and far side. And then I can update it. And I can move. Whereas with colour I can't do that. I can't see. And I keep moving it until I catch it. I'm going to open it. Open it. Open it. There. Stop breathing.
Nín thở xíu nè.
There you go. Yeah. So, I mean, if you look at that regarding jet, it's quite significant. You know, that's 1.5 meters, and it gives us understanding why we see that the aorta is so narrowed with the VSD present. It's not so much that the aorta is so narrowed; it's more that you've got pulmonary valve stenosis with pulmonary valve dilatation. Yeah, interesting case. Okay. Anything else? I'm just going to do a sweep. So if we do a summary, we have a baby where we can see that there's bilateral cord plexus cyst, the key findings, we just put it in a 4-quadrant. We can see that there's bilateral cord plexus cyst. We can see that the head is strawberry shaped. We can see when we're looking at the heart that there's a ventricular septal defect. We see that the left cardiac ventricle is smaller when compared to the right. We can see that there's a ventricular septal defect. We can see when we look at the 3-vessel view that the pulmonary artery is larger than the aorta, larger than the SVC. And then we can see when we look at the pulmonary valve that the pulmonary valve looks thickened. And then when we look at color Doppler examination, we can see that there's pulmonary valve regurgitation. And we can see there's quite significant regurgitation as we look at this. And then when we look at the, coming down to the very last image, when we look at the aorta, we see that there's quite a significant narrowing of the aorta. And they're the sort of the key findings all in one.
How do we differentiate between the stenosis with the absent pulmonary valve, because we see two directions?
Very good question. Yeah, very good question. The answer lies is, first of all, absent pulmonary valve syndrome. The vast 98% of these coexist with tetralogy of Fallot, so there'll be aortic override, but the aorta will not be dilated. But that aorta is too narrow. I think. Well, let's look. But to answer your question, absent pulmonary valve syndrome, the vast majority of these coexist with tetralogy of Fallot. About somewhere, depending on the published literature, between 1 to 5% of absent pulmonary valve syndrome occur with an intact ventricular septum. So, if you go for most with absent pulmonary valve syndrome, if you see that two-flow motion, you also see aortic override, dextroposition of the aorta. Yeah, and then you know it's absent pulmonary valve syndrome. This case, you're suspicious of absent pulmonary valve syndrome because you're seeing the velocity back and forth is very similar. You're saying, is it absent pulmonary valve syndrome? The next question is our features of tetralogy of Fallot, is there aortic override? It doesn't fit because the aorta is so small, but we look at the aorta now to see if there's a aortic dextroposition, in which case you could be looking at tetralogy of Fallot. And if you're looking at tetralogy of Fallot and you're worried about 22q deletion, then you go on and look at the thymus gland to see if the thymus is shortened.
I think the tetralogy of Fallot has, including the pulmonary stenosis, not a big pulmonary valve.
No. It depends. With the tetralogy of Fallot, there are two types of pulmonary stenosis you get. There's infundibular pulmonary stenosis, which is obstructive pulmonary stenosis. And in that situation, the pulmonary artery is small. Yeah. And then there's pulmonary stenosis, which is pulmonary valvular stenosis, in which you can get dilatation of the pulmonary artery. If you look at this artery is dilated. So in a sense, it's likely to be explained by a primary pulmonary valve problem. I don't think this is an infundibular pulmonary part of tetralogy. I don't think so. Yeah, but there are two types of things.
But in case of the absent pulmonary valve, it means there's no valve in the last position. Right?
No, it's a bad term. No, there is actually a valve. Yeah, there is actually a valve, but it's dysplastic. Yeah, it's a very bad term, absent pulmonary valve syndrome. It should be dysplastic pulmonary valve syndrome. The other thing is that babies who've got absent pulmonary valve syndrome, they have no duct. And when you see this case here, you can see that the aorta joins the pulmonary artery. There's a duct present. So that doesn't support. That doesn't support. Yeah. So if you look at the 3-vessel tracheal view, you see that it joins at that point. Do you see the way I'm getting reversal of flow along the aorta? Yeah. sometimes you can get that with babies breathing motion, but that worries me in the sense that you're seeing, reversal of flow along the transverse aortic arch in the baby at 16 weeks of gestation. I know that you're worried about trisomy 18, it's got bigger problems, but if you just see that, yeah. So in babies who present with coarctation of the aorta, for most babies who've got coarctation of the aorta, you see reversal of flow along the transverse aortic arch, but you see this, in the third trimester of pregnancy, not at this very early stage. Yeah. Stop breathing.
Nín thở xí.
Breathe away normally.
Rồi thở bình thường.
When you've also got left-sided heart problems, you can see here you've got your ventricular septal defect. But if you did not have a ventricular septal defect, you would also look for tricuspid valve regurgitation, which is another feature you will get with left heart problems where there's obstruction. And one of the first things you may see is tricuspid valve, but there's not tricuspid valve because it's a big VSD in this baby. Let's just go back and look at that regurgent jet. You see, with absent pulmonary valve syndrome, you get a very different picture in the flow. So this would be flow that would be fully blue and then fully red, equal volume. You're not getting that. You're actually getting full flow here, and then you're just seeing a little jet of regurgent, again, which tells you it's a primary pulmonary valve problem. Yeah. So if you look at when you come down to your paradoppler setting, next thing if you reduce your PRF, you will see just coming off if there's any evidence of an aberrance of Clavian. So left is down, right is up. And as you come off here, you want to know whether there's an aberrance of Clavian artery coming off the tip of the aorta. So your reference mark is if you look at it here, your reference mark that you want to look at here is your trachea. So just look at your trachea when you come up to the three vessel tree. I have too much color here, hold on, let me bring it up. So if we look at the three, and again, my box, always maintain your box as being really small, right? Because you want to get maximum clarity of what you get in color with a small box. When I see this here, I'm also seeing that there's a vessel here coming out here, and I can see it on 2D. So if I come down to the three vessel tracheal view, just at this point here, and I then seeing this vessel coming off, and to bring that into view, then I will reduce my PRF, and then I'm beginning to see what looks like an aberrance of Clavian artery, and it's going behind the trachea. Yeah. So I think that's an aberrance of Clavian artery because it's running in behind the trachea. Yeah. Just have a quick look I'd just like to have a look with the linear line on this. Thank you. I'll start. We have another case outside.
Okay.
Thank you very much.